understood with time. And I think sir will highlight these points. And I am a student of Amit Joshi sir, and Dr. Amit and I were under sir only for a long time. And that is why uro-oncology is one of our most highlighted and favorite areas because of sir.
It's the cure rate is the, so I think oncology, we thrive for the cure rate, and fortunately with the development all over in the oncology and with the testicular cancer, the prime model where we see a long-term survivor. So that is the reason I just have an interest in that. So and same is happening with, I think, metastatic hormone sensitive prostate cancer. Also the survival is definitely improving over a period of time. So I think we're the panelist. Achha. So Saurabh, I think
Dr. Amit Kumar, medical oncologist, Dr. Lincoln and Dr. Prashant are radiation oncologist. Dr. Lalit Agrawal sir is a neurosurgeon. Dr. Manikandan is nuclear medicine. Dr. Shreya Shukla is a radiologist. Dr. Pooja is our colleague, medical oncology colleague.
Pooja is there?
Pooja is there. Pooja is continue to that.
काटा में बहुत ध्यान रखना पड़ता है. I think it will be just a presentation or what we see in our OPD. So I think everyone can pitch in whenever anyone wants to have some comment. So it might be, the discussion might not be very much scientific, but practical, that what we do in our practice when we see. So this is a usual presentation we see in our, I think was discussing the most of the patient present with the some sort of a LUT symptom and a catheter up 2 weeks. So I think that's a not good sign for the radiation oncologist, because that for that reason. But this is the usual way most of the time they present with a LUT symptom, and then by general physician they refer to the neurosurgeon, and then we come into the picture. So this is the presentation. So Himanshu, how you would like to? Then the patient will land to you, it will not come directly to us. So how you will like to investigate further this case? What sort of additional investigation or will you do in this case?
So, sir, patient landed into acute urinary retention. That's why he needed a catheter insertion. So, looking at the hard nodular prostate with the PSC 254, prostate biopsy is by any means is required.
So the next question comes to, in a day-to-day setting, or do we need to consider a biopsy prior to going for do MRI prior to doing a biopsy?
Surgeon, we have planning for a radical procedure. So looking at a patient with a 71 no morbidities, having a good life expectancy, we can go with the MRI prior to the biopsy as well. Otherwise, if MRI is not done, because we see many patients in our clinical practice, the patient present to us with the biopsy or the biopsy report without a prior biopsy. MRI for local staging can be done 40-45 days after the biopsy is done. But if a near patient comes to me and I'm planning some sort of radical procedure, MRI, I'm trying to go for MRI.
So yes, you want to go ahead with MRI. So what sort of a feature? I think the only thing is that for radiologists, we don't have much first. So this is the time when our radiologists come into the picture. So what sort of pyretes will you, and how you report a pyretes in an MRI, and what should be the threshold for as a clinician to go for further workup in an MRI?
Okay, so PIRADS, as all of us know, is PIRADS imaging, prostate imaging and reporting data system. Like any other system, it helps us decide how high risk or low risk the lesion is. So in a multi-parametric MRI, we use basic sequences T2, diffusion, and dynamic contrast enhancement to characterize the lesion. First, we see whether the lesion is best seen on T2 or diffusion, and we localize whether it is in the central gland or it is in the peripheral zone. In peripheral zone, the importance of T2 is more. In central zone, the importance of diffusion is more. So in the peripheral zone, when we see a T2 hyperintense lesion, we go on to see the diffusion sequence. If the lesion is restricting on...
So for a clinician like us, so what should be the PIRADS among the when we should go for a
So Pirates 3 is a gray zone. Pirates 4 and 5 is when we are quite sure it is a suspicious lesion. Pirates 3 is when even prostatitis can make us feel it is a suspicious lesion.
so for a day-to-day purpose, 1, 2 we can wait. 3 is a gray zone. 4, 5. Yes. So 4, yeah. 4 and 5 is the thing which so in this patient where the PSA is
particular.
so in this case it might not be relevant.
So much relevant in this case because patient is already having a PSA.
Yes. So that this was so if the PSA would have been 25, then the discussion.
Basically, for basically it has a its importance is its negative predictive value. So MPMRI is negative predictive value is important. So it goes in the range of more than 95%. So it detects the clinically significant prostate cancer because at the age of 70 or 75 or 80 years, we will definitely have some kind of some sort of prostate cancer focus in up to 70% of the patients. So this is the data in 70 years of
Yeah, so it's a 3 plus 3.
Holds its importance in its negative predictive value. So whenever the PSA is lies in the range zone for 4 to 10, then the importance of MPMRI is more. So to decide whether to go for a biopsy or not, we can safely avoid the biopsy in a patient having a PSA in the gray zone. So in this patient.
So I think the cutting short this. So in a patient which are presenting with a very high very PSA may not be, but in a patient where there is as such like if the PSA is 25 or 5 or 10.
Even the patient in this scenario, if patient is having a PSA of 10 with hard nodular prostate. So basically, it's a DRE along with the PSA. DRE is highly sensitive in the range of 57% alone. It can detect the prostate cancer. So if suppose if the PSA is 10 or 15 and the DRE is normal, no nodularity, no hard prostate, then comes the role of MPMRA, a definite role of MPMRA. So with this hard nodular prostate, we can straight away go for a biopsy.
That's what I want to add. If prostate is hard and PSA is 250, so there are very high chances of metastasis.
So what I meant for this purpose that these, if you go by guideline, the answer is yes, but these guidelines are mainly for a Western world where this sort of presentation is very rare, where the patient comes early. In those scenario, before doing a biopsy, we should go. So the purpose of this discussion is that ideally yes, but in our scenario you might not, because with such a high level of PSA, there is a good probability that we are dealing with a metastatic disease agent. And then how many course is sufficient, and what and the discussion of which is going very much hot in the current era, the transperineal versus. So just a quick thought that what are the problems of a transrectal biopsy and how the transperineal biopsy can be helpful, and what is your thought? Do you think that transperineal is better than transrectal?
So the practice here is doing transrectal biopsy and we take 12 cores. Transperineal biopsy is emerging, but the basic difference or the advantage of doing a transperineal biopsy over a transrectal is that it reduces the chances of infection.
Yes.
Technique-wise, both are similar. Detection rate-wise, both are similar. The only advantage being that infection rates are lower.
Yeah, so I think that's important. And then as the learning curve, the trust guided biopsy is well established at this point of time, and then when we pass this learning curve about doing a transperineal, then I think people are gradually shifting to the transperineal. In Tata, we have just started, so I think.
So yes, transperineal is a painful procedure.
But in current era, I think if you see one life-threatening infection with trust-guided biopsy, you will done with that. So I have at this point of time, I have seen 3 deaths post trust-guided biopsy. So if the chances of infection is less, even doing a short GA is not that much. Yeah. So then due course of time, and then the question comes, how many course will be? So Akhil, I think Amit is there. So how many course will you really want in this case?
Standard is to take 12 course. But it is only the image guided if we are getting from that side. That's the
So suppose the patient would have already a scan which is showing multiple metastatic disease, multiple. Do you still want a 12-core biopsy in that scenario?
So if it's an advanced, it's only on the image guided side biopsy.
So I think that is important that if there is a meta, so the purpose of 12-core guided, more relevant in this scenario where you are dealing with a localized disease where or when there is a decision for keeping the patient under active surveillance or not, depending upon how many cores involve PNI and there are not. But in a frankly metastatic disease, if you want a tissue, you can get away with the less course of course also that. So I think the data is that strong data is that you should do, but in our country we have to prioritize as per our patient need and can be avoided in this scenario. But definitely the trials have taken the patient which are less than 15 and so mostly a non-metastatic scenario. So then the next question, which was I think already discussed. So how comfortable you with the CCT and bone scan? I think our medical oncologist can take. So if the patient has come with a CCT and bone scan, do you still want a PSMA PET CT or yes or no?
So currently, if the patient is having a high PSA level and the patient symptomatology also addressed, so I would like to do the PSMA PET.
No, patient has already done from our outside, have come with the CCT and bone scan. Do you still like to go ahead with PSMA PET?
Yes, I would like to go for PSMA PET CT because to see because sometimes PSMA PET CT can upstage.
So bone scan is already showing 3 or 4 metastatic disease. Then still you want to go ahead with PSMA? That is my question.
So, sir, I have a comment. So whenever we are dealing with a prostate cancer, we should see first the life expectancy of the patient.
No. So it's a run of the mill case, 70 year. Otherwise, fit. That's a different question. That way. So in a fit patient, relatively fit patient, 70 year, do you need to do a PSMA PET CT when the CCT and bone scan already done and bone scan is already showing a.
So the burden of disease is accurately calculated on the CT and bone scan. I will not like slow volume or high volume disease what we decide before starting a treatment. So if it is adequate on that CT and bone scan, I will not do that.
You will not do that. I think we take the Lincoln opinion.
Sir, I would say if PSMA PET is not going to give me any additional information which is going to change my line of management, then probably I will.
So I think it's a little bit difficult. So the patient is already, because all the trials and all that have done with the CCT and bone scan. So if you see the inclusion criteria for all those landmark trial, either you take the Charted, Latitude, Piece 1 and all that, they have already included the CCT and bone scans. If the patient has done a CCT bone scan, which is already showing a clear-cut metastatic disease, the incremental value of doing a PSMA PET CT is not very clear. So we generally avoid it. But if the bone scan has not shown any lesion, then it's debatable whether you want to prove a non-metastatic disease to a oligometastatic disease. So that's another discussion, I think.
Pick up more lesions, there is no doubt in that. It is better, the necessity is better. But what do we do with it? So if I pick more, I pick one metastatic lesion, which was non-metastatic, there is no data to say that.
Yeah, so yes. Yeah, so you are absolutely right that in this scenario, if the PSMA PET CT has not if it has not been done, and if you have to select one modality, then it can be in our. I think Mahendra wants to add anything in that.
Just to put up in a different way, because if we see the M staging of prostatic cancer, it is M1, M1A, B, and C, and only bone scan not going to address this M1A, A and C, I guess.
So if the CCT has been done, that
will not pick up something very. It is equivocal finding the CT scan.
No, the radiologists will not agree.
No.
And even I will not agree. If a good radiologist reporting a
lot of time, other thing. Yeah, but it's practically not possible. Practically not possible. Whole body MRI can be equal to the PSA PET scan, but it's not feasible. And
We will do a PET MRI, don't worry. That will both component.
To have the management plan like oligomets, I think both is not the modality of investigation to decide oligomet or low burden high burden disease.
I agree with you, but the issue is that oncology goes on a trial. So whatever the trial which have included the bone scan and CCT as as their baseline investigation, doing a BSMA scan might either will push the patient on a higher stage or lower stage. So there might be a stage migration for these patients. So if you see the scientifically, CCT bone scan is good enough, but for practical life purposes, all over India, I think hardly 10% people are doing. Otherwise, 90% neurosurgeon or a medical oncologist so they are, and with the availability of the scanning procedure. So I think that there's many other things to discuss. So in short, CCT bone scan is the standard, but in a practical life, we are going with the PSMA PET-CT because of the same cost and the easy availability. We don't know whether this doing extra is helping or not. That the time will tell this answer. So I think it's the better detection in that. So I think this is the guideline which we discussed, and I'm pretty sure that in due course of time, next year when we meet, this will change, and that will say that PSMA PET-CT is the standard of care. So is there any situation where you will like to consider doing a FDG PET in this situation?
Yes, if the biopsy comes with any such that there is a neuroendocrine component, then we will advise the clinician to go ahead with FDG PET-CT, because if there is neuroendocrine component, PSMA PET-CT is not the sensitive modality in this condition. So we advise them to go ahead.
But if the patient has already an FDG PET-CT and there, because as usual, the local place physician has already advised FDG, and then so if that is already showing a clear metastatic region FDG PET-CT, then there is no incremental value of doing a PSMA PET-CT. So I think it's. Yeah, so that is the next question which I have written, that so it's not required in every cases. If the biopsy is suggestive of some sort of a neuroendocrine, there is a sclerotic metastasis, visceral disease, then it can be. But in a run-of-the-mill case, PSMA PET-CT is sufficient. So I think we'll just discuss with our medical oncologist. So I think, Dr. Pooja, do you really want to stratify the patient for volume or burden of the disease before planning a patient? So PSMA PET-CT suggestive of 3 or 4 bony lesions. And do you want to take this information in management of this patient?
Exactly, sir. So now, as we have seen the definition of the high volume body disease is there is any distal metastasis or there is a bone mass more than 5, even the one lesion outside the vertebra. So we have a multiple combination treatment in along with for the chemotherapy also and anti-androgen. So definitely the chemotherapy role has been proven for the high volume body disease with docetaxel.
So what about the non-rich? Suppose the patient is presenting with multiple para-aortic node and few of the supraclavicular node. Which classification will you follow, or what will be your management in a patient which we see no bony metastasis but multiple nodal involvement? So
that way also there is a multiple nodal involvement that is not usually seen with the prostatic cancer because the bone is the most common site for the prostate.
But we see.
Yes, that's why I would like to treat the patient as a high volume burden disease, and in that scenario, my treatment point will change based on the disease burden of the patient with low volume or high volume.
It's only nodal disease.
So, but the supraclav is.
Yeah, Amit, what's your take on that?
Different criteria for the high volume. And for the nodal, it is not clear. So different even though the body they have taken into consideration.
So that's the discussion I want to be. So I think Saurabh, but
nodal disease, I think it's aggressive disease. We should take care. But
no. Do you want to treat as a low volume metastatic hormone sensitive prostate cancer, or you want to treat with ADT alone, or I think our radiation oncologist can also come into the picture.
The nodes are, you are telling supraclavicular nodes.
Yeah, supraclavicular. It's a non-regional lymph node practically.
So An aggressive, like aggressive malignancy means like with chemo and ADT is what? Metastatic stage 4. It is supraclav node and
I
other
think
nodes
I
also.
will ask Akhil to. So, non-regional lymph node, metastatic hormone sensitive, no bone involvement.
These patients are
Time हो गया क्या?
timing.
So I think we can discuss prostate the whole day.
Coming to this point, non-regional node and prostate cancer. Yes, we know that these are some definitely more aggressive disease as compared, and also these might be there might be some focus of small cell component or other which we need to understand. These are actually somewhat more like aggressive. So that picture also comes into our mind, and we would like to incorporate some form of systemic therapy, whether but incorporating a triplet treatment in such might not be the best part. We should incorporate at least one of the systemic treatment in the part of the treatment. That is what I consider, sir.
So I think yes.
Sir, even the non-regional lymph nodes comes before the one stage. That we have to remember. As the stage increases, the prognostication, adverse prognostication increases. So M1 is the non-regional lymph node, then comes the bone, then comes the visceral.
So I think I agree with Akhil. So in this scenario, although technically it's not included in the classification, but we may take it as a low volume metastatic. So ADT plus something, and then after 6 months, yes. So that discussion can be considered depending upon the response after 6 months. And you want to say something?
Radiation has come from the Stampede trial. Unfortunately, Stampede trial did not have many patients which were this, that is parietic node positive. So we don't have true data to say that radiation helps in this particular term.
So we have to individualize the treatment. What we do that, give them the ADT plus something, and then reassess after 6 months. If there is a very good response, then we can have a discussion regarding the role of at least the prostatic RT, and then metastatic site. Still, that is that.
Our practice has also been heterogeneous in the 5-10 patients we have seen.
Yeah.
The patients with had few parietic nodes. We have in fact treated the parietic along with pelvis and.
So that is the discussion we usually have in ADT. If you can teach up to the common, like why you can't increase the portal and cover, what's the harm in covering the portal with the parietic lymph node?
It's not different, sir. Covering both. Only
So as a medical oncologist, we feel that you can radiate from the parietic to the common.
Be comfortable in treating if the patient is having upper parietic. At least up to renal hilum, we have treated 3 to 4 patients of lower parietic or just at the common area. But I don't think we should take this as a routine. We can take it as a routine practice.
Suppose if the patient responds well after 6 months and the disease has responded very well, do you like to treat the prostate or not?
Here also the answer is not clear.
Yeah, but what you will do? So medical profession is a subject where you will not get an answer. You have to decide something which is best for the patient.
As I said, below the parietic area.
No, not it's parietic upfront.
Yes, sir. Parietic upfront, but not supraclavicular. If it was supraclavicular, then I would not go for the local therapy.
Even you would not like to treat the prostate.
Yes.
Parietic node, but it is not only lower parietic.
Upper parietic.
We have given abiraterone for 6 months.
Yes, that what we are practicing. That if there is a good response to the therapy and after 6 months, then we may discuss with our radiation oncologist. The prostate RT, I usually push for the prostate RT, whether to give a RT to the parietic, that you told that they also say that if we have to treat the parietic, then the bowel and all that will come into the picture. So for that, plus minus, but I will push for prostate RT, extrapolating the Stampede data from that. So I think that question we have, that question, but unfortunately the evidence is not that strong compared to that. So I think we'll take the question with Amit. In a metastatic, does the low PSA give some hint or that it worries? Do you give some worries to you? Yeah, so I think that is important, that if the proportion of the disease is too much and the PSA has not on that higher side, definitely the worry comes into the question whether there is a neuroendocrine component. And in that scenario, sometime FDG may be help. So do you want your pathologist? I think there is no pathologist in the panel. So in those situations when there is a the disease burden is too much, the PSA is not high, then definitely you ask your pathologist to look for any neuroendocrine component, because this behavior of these tumor will be entirely different compared to the Gleason 7 or 8 compared to the Gleason 10 with a low PSA tumor. So I think the next discussion for the surgeon side. So which androgen deprivation therapy will you prefer in day-to-day setting? The orchidectomy versus agonist versus antagonist. And we'll just quickly go to that.
We give all options to the patient depending on the patient preference and the cost.
So in a MPMC, for a general, so affording patient, definitely for a general patient who are not affording and he wants to decide you for you, then which will you prefer?
For general patients which are not affording, either we give the early date within 2 weeks, like for orchidectomy. Otherwise, we give single shot of injection of leuprolide.
Why 2 weeks for a orchidectomy? It can be done in the evening also, na?
There is long waiting.
Orchidectomy can be done in a local. You don't. So that is the discussion with our. I think Mahendra is not. So I post that. Why don't you post in the?
There are many things we have to put the SPC. Many patients, many trauma patients, gynae patients. So that's a medical college scenario.
But still, I so that we'll discuss. So so in
medical castration and surgical castration equal, timing of the castration means the time to achieve the low testosterone level is relatively fast in surgical castration, then LHRH antagonist, then LHRH.
So I think that's very well concluded that the rapidity of fall in the testosterone and similarly the PSA is fastest with the surgical castration, and if there is any some sort of urgency like cord compression or urinary impending compression or a urinary obstruction, then definitely
then we prefer the LHRH antagonist. Even in the cardiac patient, the safety profile is better.
So I think we'll just go to that. But this is the hype which we discuss in all the meetings, that what is the data of what is the evidence that GnRH antagonist versus agonist. So in which scenario you will prefer a antagonist over agonist, apart from the rapid reduction in the testosterone level?
You have already mentioned impending spinal cord.
That apart from that, is there any, because the cost of antagonist is much higher, the frequency that is used to take is more, they have to come monthly for that. So do you still feel that?
So other than these indications, if there is a cardiac patient safety profile is better theoretically, and if patient is compliant, he can come in follow-up 1 monthly. Obviously, we have to give injection 1 monthly. Then we prefer the LHRH antagonist. Otherwise, we have to follow up the patient by PSA 3 monthly. So LHRH agonist frequency is also 3 monthly or 6 monthly. Then
what's your take on call? You are sitting in a Medanta, so you don't have any monetary restrictions. Do you still feel the antagonist is better than agonist, or antagonist is still better than surgical orchidectomy in a metastatic patient? Better for the hospital.
So I think also the patient about all the modalities and give them the choice.
So I think the discussion which was I think very much hyped from the company side, the benefit in terms of the cardiovascular morbidity with the antagonist is much more hyped. So if you read the paper in depth, the antagonist has reduced the incidence of CV in a patient who is already having underlying comorbidity. So if patient does not having any underlying cardiovascular comorbidity, then the benefit of antagonist has not shown. In a patient of established cardiovascular, so if he does not, then so in a day-to-day practice, generally, if the patient is not very keen for a body image or like thing or a Western world, I generally prefer for orchidectomy. And if you see, is there any data to suggest that this is one of the paper of JAMA Oncology, it's a 2016 paper. So what in there they have done, they have compared from 1995 to 2009. So they collected all the prescription of agonist and antagonist and the surgical orchidectomy, and they followed all those patients in subsequently. And what they concluded that surgical castration was associated with the, so it's not a direct comparison, it's an indirect shared database, but it's a number of in thousands. So what they concluded that surgical castration was associated with lower risk of any fracture, the hazard ratio 0.77, peripheral arterial disease hazard ratio 0.65, and cardiac complication 0.74. And compared with, so in some patients who needs permanent androgen suppression, surgical castration may represent a suitable alternative to the medical castration. So I think after reading this paper, I am pretty clear in my mind. So with doing a doing a castration, that means surgical castration, so significant direct and indirect cost benefit in favor of bilateral orchidectomy as one-time cost, local therapy, and the money which is saved by doing a surgical castration will be utilized for giving them the AB, angina, and chemotherapy. And later on, when we know that the patient needs a lifelong, so for a locally advanced where you need 2 years, 3 years, then the question. But for a surgical, for a metastatic hormone sensitive, I don't have anything. Even patient is affording, I tell them that you need this injection lifelong at the time you are alive. So why not to go for a bilateral orchidectomy? So what, Himanshu, you have some counter?
We have patient population. So in metastatic patients, still the intermittent androgen depression, what was happening that the medical castration helps in intermittent androgen depression.
So I think, yes, so I think that is still debatable, and this discussion is again recoming whether to, but at this point of time, in a metastatic, I don't think so that anybody, I don't think so that.
I have seen many patients who come from villages and far remote areas. तो patient आता है, he is symptomatic like impending or cord compression या painful body meds, उसको हमने anti-androgen दिया, sort of agonist और antagonist, so patient एक दो dose में he is up and over. उसके बाद वो आता ही नहीं.
Compliance is another issue.
100% उनको तो
उसी दिन शाम को कर देनी चाहिए पकड़ के आर्किटेक्ट.
practically
specific indications for the ADD, it should be a patient choice and then the patient compliance. Right? And the two factors should be that you decide which therapy we should offer and which therapy they should accept.
So
in my opinion, अगर हम उसको आर्किटेक्ट में और उसके प्रॉपर्ली ईमानदारी से बताते हैं ना, तो बहुत सारे पेशेंट मेजॉरिटी इन हाई क्लिनिकल प्रैक्टिस आर्किटेक्ट चूज कर लेते हैं, चूज करते हैं. It is 30% who go for the कई पेशेंट ऐसे होते हैं जो अल्टीमेटली इंजेक्शन के बाद जब उनको पता चलता है कि हर 3 महीने में 12,000 खर्च करना है.
So that's what I am telling. That's what I am telling. We should, in our country, we should push for until unless there is a strong data vision, which I don't. So I think there are many things to discuss about other than the architecture. So that is beneficial for surgeon. So you will get one additional. So if they go on a medical castration, they will not go to you.
कर दिया लोग डॉक्यूमेंट ना दो तो कहते हैं सर ये तो मेरे साथ क्या कर दिया, जब दवा थी तो मुझे बता देते सर ये तो करानी थी.
It's the better communication and it's a scientific data. It's not that our choice. It's the scientific data.
It's the patient choice.
Hmm.
We should give them equal options and consult both the things in detail.
For lifelong. 80% will go for a. So I think we'll go ahead.
Paper data will be thing good that it is the clinician who मरीज को किधर ले जाना चाहता है.
So in Tata, we want to take where the evidence is there and where the patient benefit is there.
खासकर इस एरिया में तो पेशेंट छोड़ देता है कि डॉक्टर साहब आप बता दीजिए.
So that is the reason I just highlighted. So I think we'll go ahead with the next question. So I think Akhil, you can tell me when to stop. I think that the usual question, what add-on? So it's a low volume metastatic disease. What add-on you will like to add with the current? I think Pooja, you can take this question. So among all this plethora of the agents, fortunately, we are spoiled with choices of many.
Based on available data, we have an option of chemotherapy and anti-androgen as well. But for the low volume burden disease, I would like to add on the anti-androgen along with the ADT treatment, as the role of the chemotherapy with docetaxel is limited in the low volume disease. So we have a high level of evidence for anti-androgen. So
which anti-androgen you will like to choose among all the 2 or 3 available, and the region for your choice.
Based on available data, so we have a abiraterone, enzalutamide, and apalutamide. Toxicity profile also favors the choosing the option among these three. So if the patient is having like abiraterone acetate, we have a high incidence of the hypertension and hypokalemia also. If the patient is having a high risk for developing hypertensive crisis and other thing, and more chances of developing the hypokalemia. So in that scenario, and also the cardiac side effect profile also, I would like to avoid the abiraterone, and I would like to opt other option.
Amit, you any particular choice among efficacy wise? What's your take on for efficacy wise among all these AR inhibitor? What do you feel?
It seems to be similar in all the subgroups. It's only the side effect profile we have to take consideration. If the patient has CNS disorders or anything to avoid enzalutamide, if there's a cardiac disorders to include over the chances to avoid abiraterone in those groups. Apalutamide is a drug which has not recently been come, but the side effects if we are able to manage like diarrhea and other things.
And the skin toxicity and variety, yes.
Again, sir, the cost is important for
Oh.
abiraterone is presently the cheapest option, and also there is data that enzalutamide can utilize after abiraterone, but abiraterone after enzalutamide doesn't have much benefit. That is why.
So looking through all the aspects, if there is no contraindication for abiraterone, we generally tends to, although the one or other is not proven, but we generally tend to start the abiraterone and keep the other option reserve.
One point I want to add, sir, if there is uncontrolled diabetes mellitus,
So then you can
we
shift to.
prefer enzalutamide.
So if there is any issue with this drug, and some data, I think emerging for the low doses cost will definitely come down in future also, if that yes. So there is some data going on prednisolone free regime, but till the time that data matures, we have to give at least 5 mg OD to prevent the aldosterone excess blockage resulting to the hypokalemia. And so I think that, so if you look to the indirectly comparison, this is one of the paper which I find reading. It seems that enzalutamide, it's an indirect comparison, but if you see the hazard ratio for each agent in overall, see, enzalutamide seems to be a little bit better. But definitely these are the cross trial data, but the enzalutamide it's around 0.53 among all the drugs. If you feel enza seems to be a little bit better in terms of that, but definitely it's a cross trial comparison with the heterogeneous data. So we cannot conclude that, but that is what we find in the I think this Akhil has already discussed about that. So I think the other more important aspect is that even though the abiraterone are oral pills, but all oral pills are safe. That I think is a wrong concept, and we have learned in a hard way in our practice. So what sort of a follow-up you will want your patients, I mean, when you prescribe the abiraterone in those patients?
Follow what I practice and to see the LFT.
Yes. I think you have. So what we do, I think since he has been trained in Tata, so that what we do, it's although oral drug, but we have seen liver dysfunction, hypokalemia, and hypertension. So 2 weekly initially for 1 or 2 visits at least, then monthly, and then 3 monthly, and a echo every 6 to 8 monthly. That we have seen that has helped in preventing the toxicity. I think these are the specific index. So the 2 times. So bilirubin is more important than so apart from OTPT, the rise in the bilirubin is also important factor when we decide for. And although the incidence is less, but in day-to-day practice, I think 3 or 4% patient will present with the liver dysfunction. So that is what I meant, that it's an oral drug. You can't tell them to come after they take the drug and come after 3 months. So that is not, you have to follow. Even for enzalutamide, we tell them to keep a watch on the blood pressure and meet at least monthly with us. So now the million-dollar question again comes. Radiation in a metastatic low volume, which patient apart from trial, which patient you will like to take for a local radiotherapy? Which subset of the patient? Anyone can take that.
So from the sample result, bone metastasis, which is low volume, that is less than 4 inches. That is one definite indication for RP to the prostate. One indication which we have no evidence is only paralytic nodes because of the low one. The dose, as you mentioned, 55 to 20.
So yes, but the discussion point for a Stampede trial, when the Stampede trial was planned, they used only ADT. So it was not the ADT with AB or ANJA. So do you still feel that in the, and I think that is the study you are, so when I came to know about that, so that is the real question, ADT plus AR inhibitor with RT. So this trial was done in a ADT alone. So the other arm is ADT alone versus ADT plus RT. So that has shown whether the adding abiraterone or ANJA has benefited. I think you people are going to give the answer for that question.
When it started, it was only ADT, but there was.
But majority of the patients have received only ADT.
So in our study, two things we have added. One is that the standard of care has been made ADT plus
Yes,
Abira.
I think-
And second thing is all patients are randomized only after PSMF better because we are achieving sensitivity.
So in today's era, you have to do a study. You have to you can't do with bone scan only. So I think now this is another very interesting and very complicated the piece one. So I think we'll take your opinion regarding the role of RT in the this trial, the piece one trial. So have you been chance to look to this paper? So
Space trial.
uh,
Space trials are in.
no, the role of RT. So PACE is it's a 2x2 design. They are
Right.
try to answer 3 or 4 questions at a time. So I think the full paper is yet to come.
The results for the first time I was not aware.
So I think it's interesting. No, so the first part is published. The role of the radiotherapy that they have abstract, and that full paper is yet to come. So the one data which for piece one is that in a high volume metastatic patient, the data. So they want to see whether the addition of RT. So the SOC, the standard of care plus AB plus RT, and then the other arm is SOC, the standard of care plus AB. So ultimately, they want to see whether the addition of abiraterone with RT and the standard of care is ADT plus docetaxel. They have amended in between. So what they concluded that the low volume in a low volume patient, the OS has not been there is no benefit. But there is one new term which I came to across, the times to serious genitourinary event. So if you see this term, time to serious genitourinary events, both even the low volume patient like stampede, there is OS benefit. But in this trial, when you combine SOC plus abiraterone, adding RT has not benefited OS till this time. But this new terminology, the serious genitourinary events, which includes the obstruction, which includes the repeated TURP for those patients, that has benefited both arms. So even the low volume and the high volume both benefited in terms of if you see the value, the p value 0.001 in this. So one way the OS benefit has gone, but in other way both. So it's a win-win situation for radiation oncologists. They can now give the local RT to both high volume and the low volume, because there is a significant difference in terms of the preventing the serious genitourinary events. If you read that closely, the 106, so it's the half, it reduce the incidence by half. So I think this is the time we have to just relook and consider RT to all patients, not only to the.
Right, so that was
But that is the science. What is
radiotherapy causes mainly hematuria, close retention. So it seems like contraindicatory how it is decreasing the.
So I think we have to just wait for full paper. This was presented in ASCO GU last year, and just shortly the paper will be there. So Dr. Bossi, the presenter, concluded that the combining prostate radiotherapy with intensified systemic treatment was associated with improved RPFS and CRBC free survival. So there is a significant difference in CRBC free survival if RT is added. In men with low volume de novo mHSPC, to date it does not appear that prostate radiotherapy improves OS in such men, albeit with minimal radiotoxicity. Interestingly, it appears that the addition of prostatic radiotherapy in this setting is associated with improvement rates of serious GU events, irrespective of the metastatic. So what they have concluded, that what I quoted here. So I think we have to wait for this paper, but this is a time we have to relook the role of radiotherapy even in high volume metastatic CA prostate also. So I think this. So I think this will be another discussion whether adding radiotherapy increases the that what you want a discussion.
With these types, what will you use?
And I agree with you. With
clinically encounter that, what I'm
so that will depend upon which center.
there is severe
No. So I think that
That's not against that.
we only see the anecdotal cases which are extreme. So we should not based our bias on that extreme, and with the current available technique, more precise technique, even when in the last 10-15 years, the complication of radiotherapy has significantly come down. There is no doubt in my, yes, no doubt about that. What toxicity we have faced in a cobalt and all that era. So I think we just should not, we should be little bit wise and take as a modality.
Interesting message.
So I think for Himanshu, so now for your question, do you want to consider metastectomy or the prostatectomy in this patient? In a you agree with that?
Yes.
So you can.
Definition is not clear for oligomets. So for oligometastatic, these again is functioned for.
So I think sometimes patient may ask about the.
We can you can. Yes, so I will just, I think we'll just conclude that this is a, I think, a little bit controversial topic, but the evidence is more for a radiotherapy compared to the RT. In case to case basis where there is obstructive symptoms, the surgery can be considered. I think this has already been discussed. Do you consider bone health when you prescribe the long-term anti-ADT? I think Saurabh, you can. And why?
Take bone health in that case because most of our patients are already osteoporotic in that.
So in a hormone sensitive setting, do you consider doing?
Yes, so this is the dose I have mentioned 5 milligram once in a year. So that is the.
So what I meant to discuss for this, the role of a bone modifying agent is not as same as we do in a CRPC setting. There we have to give every monthly, but in the osteoporosis prevention setting, either it's a yearly or a denosumab 60 mg 6 monthly. That is a osteoporosis prevention. What we give in CRPC is a preventing the SRE, the skeletal related complications prevention. So what the, I should not say, but the usual practice to write the zoledronic every monthly, that should be strongly discouraged in hormone sensitive prostate cancer. That is for a CRPC setting, not for a, and in a best practice, do a DEXA scan, keep that in your the papers, and you compare later on. If there is a further osteoporosis, then you can.
Duration of the zoledronic acid, or how much period we have?
So for osteoporosis prevention, you can continue. There is no problem. For a CRPC setting, it's a debatable. We generally stop at 2 years. If patient is not progressing, we stop it then, or we increase the frequency from 1 month to 3 months. As such, no scientific basis, but that is a practical way we deal with this situation.
As per the race, as per the age, regulate the risk of that can be done before the child.
So one important message when patients are on denosumab, we should not abruptly stop the denosumab. Because when we abruptly stop denosumab, there is a high chance of fracture. We should give 1 dose of zoledronic acid when we are planning to stop denosumab. And then we can stop it permanently.
I think we'll just take the list as a last question. The usual discussion of a triplet in a high volume metastatic patient. So which patient, Amit, you will like to consider, and which regime you will prefer?
Age is one of the things we take in consideration. Slightly younger, earlier than 55 years patient, and it's a high volume disease. Or more than 55 with patient able to tolerate the triplet regime, then I consider.
And which triplet?
So in that case, it's basically the best thing is the docetaxel plus and the new darolutamide is coming picture. But at present, what we are focusing is the abiraterone we are adding with docetaxel.
So I think the other thing which we look towards the timing of that. If it's a, because all those data is for a synchronous high volume metastatic prostate cancer. If it's a metachronous disease, the data is not that too strong. And unfortunately, we see majority of the synchronous disease where compared to the Western world. So I think that is one thing which we can consider. And as the discussion is going on, that if darolutamide available and affordable, that is the, I think. So I think we'll just skip this because since we don't have, but only thing is that the toxicity of abiraterone and darolutamide may be some issues. So what about 70-year patient, elderly patient? Do you still want to give the triplet?
Might be geriatric scoring, and after seeing that if the patient is fit enough, it may go. In most cases,
Pooja, what's your?
I also agree with Amit. Some of the patient performance, geographic scoring, comorbidities, and the fitness of the patient, all these are the important factors to decide whether to go for the triplet or to stay with the doublet.
So I think we'll just skip this.
Just more, but
Mm.
SPOP gene mutation is coming up very rapidly. And the patients who are having SPOP gene mutation,
Yes, so I think
20 to 25%
so,
of the patients, they are single agent abiraterone or will be a very good.
So what we were discussing in the morning, that we are on the verge of going into the molecular era in the metastatic CA prostate. So after 2 years, when we will meet, we will discuss that among all these, which patient requires intensification and which patient require de-intensification. So I think we are reaching to that time. Till this time, I think we have to go by this chart. And I think the only thing which I want to discuss with our medical oncologist, do you still feel that we have reached to this survival of a median survival of 60 months or 72 years? Do you see in your practice our patients surviving, 50% patients surviving to 7 years? Because I don't see that number of patients. So what's the reason for that?
We are seeing as compared to the metaclonal which are happening in that.
But in this study, only the synchronous have. So what are the factors which increases survival to this range? I think Akhil, you can also comment on that, because when I look into the data and I look our patient, I rarely see, or probably the resident are not showing to me. So whenever the patient recurs, I feel that triplet with Dia and then it's coming back in 8-10 months. So
this is what we also observe. Even the aggressive treatment like in high volume disease, we don't see so long outcomes. It is most likely related to difference in genetic makeup.
I think
SPOP gene mutation, which is present in Western world to the 25%, we found it only 5%
in our
it's
population.
Initial data which we have done.
I think that may be.
SPOP gene mutation testing.
And that's good thing you are doing. At least we can have one answer for this question. Dr. Miki Misra, what's yours? I think
it is late detection in our patient or disease biology may be little different, because many of patients coming in our hospital, they are already harboring disease for more than 5 years, so already completed 2 years before the coming for the treatment and taking other treatment. So this may be after awareness, or maybe disease biology may be the reason.
I think I feel so. There is some different biology compared to the. So we are close to the African population compared to the Western population, and we know that African native have a more aggressive biology, blacks and all that. So I think that is the reason we do not see that. So I think we'll just, what the question which we are discussing, in a 90-year-old, do you still want to add? No, for them the ADT is sufficient and to consider that. I think we'll just sum up. So in summary, the biopsy is yes, and in the current era we need biopsy, because for the molecular studies also, PSMA, PET CT, we definitely need counseling with the patient. That is most important, to tell them about how the patient is going to do in future. ADT, I discussed that, and definitely. So the message is that in current era, for a metastatic hormone sensitive prostate cancer, ADT alone is not the standard. Something has to be added. That something can be ABIC, that can be ENJA, that can be docetaxel. So ADT alone is not the standard in current era, because the available data which has come, and triplet in selected high volume is now becoming